Great, thank you. Well, thank you very much for the privilege of the podium here, guys. And on behalf of my co-authors, and especially Dr. Pappas, who we are all very, very grateful to for the study, I'd like to present our data. Now, we're going to be talking about long-term effectiveness of interventions on the iliac veins for pelvic venous disease. And we had presented at AVF about a few years ago our initial data on endovenous therapies, they being the current standard of care for managing pelvic venous disorders. And what we had reported at that time was only 3-month data, and today we are reporting 24-month data. The purpose of this investigation is to determine the long-term durability and clinical effectiveness of endovenous therapies. So the way we looked at our data was in a retrospective fashion. This was prospectively collected data, and the patients that we looked at were those who were intervened upon between January 2017 and December 2019. Our exclusions were patients who clearly on IVUS we could see that they had thrombotic disease, or patients who for some reason, either due to patient preference or treating physician preference, had a venoplasty performed. In our previous study, we had included that subset of patients, but in this study, we excluded that subset of patients. Our routine investigations were normal investigations that are done in this case, but one thing, every one of our patients with pelvic venous disorders had to have an OBGYN evaluation before we could intervene. And then we collected serial interval visual analog pain scores, and our long-term durability was basically assessed on how the patient did with serial VAS scores. Total number of patients in this study are 387. We have a 63% 24-month follow-up rate in this subset. The earlier patients up to December 2018, we could get up to 82%. The second subset, we are still collecting that 24-month data. However, it was a little lower, but the total 24-month follow-up is 63%. Patient demographics, if you look at this as expected, and we've all learned as we've gone through this exercise. Early in our previous presentation, our things were that we would first always treat the ovarian vein, and then if the patient still had symptoms, then we would go treat the iliac vein. But over the years, we have changed our protocols, and in that process, we've also understood that these are two subset of patients. Patients who need embolization alone are different, and the p-values were different with respect to age, BMI, total number of pregnancies and births, while the patients who needed stenting or stenting and embolization were a different subset. So for presenting symptoms, the commonest presenting symptom, the pelvic symptom, was postcoital pain. In fact, I think we are now very, very confident that patients with postcoital pain, and as was one of the presentations earlier, that these patients would say it takes them 3-4 hours to get better. That is kind of pathognomic of this. Once we have an OBGYN clearance, and these patients were treated and did very, very well. The other key symptom was chronic pelvic pain. And in all subsets, these were the same. One other thing in the previous slide, vulvar varicosities were one of the least common presentations in all three subsets. So with respect to patients with leg symptoms, we saw that, again, all these patients also had chronic pelvic pain or had pelvic discomfort. And in addition to that, the commonest symptom here was leg pain, and it was lifestyle altering. And at the same time, we would have the second common symptom here was leg heaviness. CEAP distribution, again, for patients who underwent stenting, they were mostly CEAP3, and also the other patients, also the commonest CEAP class was CEAP3. And after interventions, the CEAP classification got better. The CEAP score was better. For stent diameters, as Lawan had presented earlier, for our patients who were earlier on in the series when we were using the wall stent, we used 18 to 24 stents, and then as we started using Venovo stents, we went down to 14, 16, and a few 18s, but mostly 14s and 16s. Stent length also, it just goes with when we were initially using wall stents and later on using Venovo stents, it just goes with that. And for the areas that we were covering, the commonest thing here was the left common iliac vein and left external iliac vein with the IVC as well. Now, the long-term VAS-based intervention type, if we look at this, all three subsets, we had significant improvement in the VAS scores at 24 months. Embolization alone had a little less improvement than the other two subtypes, but all showed significant improvement. Again, showing it in a different format, that the improvement was pretty consistent during the 24-month period. So in conclusion, the majority of women who present with a pelvic venous disorder secondary to pelvic venous insufficiency demonstrate either an isolated iliac vein stenosis or iliac vein stenosis with a refluxing ovarian vein. Isolated ovarian vein reflux alone as a cause of pelvic pain is uncommon in our setting. Our data indicated that current endovascular techniques targeted to the patient's individual anatomic cause of their pelvic pain demonstrate long-term durable results up to 24 months. Thank you.
Thank you for the presentation.